Great. Thank you for coming to the colorectal section of this symposium. Our first speaker will be Dr. Michael Truitt, who is the General Surgery Program Director at Methodist Dallas Medical Center, and he's going to speak to us about damage control surgery for diverticulitis.
Thanks so much to the program committee for the opportunity to speak today. This is a topic that over the last couple of years I've spent a fair bit of time, actually at the first impetus from SAGES as a part of the consensus guidelines between SAGES and the EAS in London. And so I was the token acute care surgeon involved in that group amongst colorectal surgeons and MIS guys. My practice is about 2/3 acute care, and then a third kind of endocrine and advanced laparoscopy and robotic surgery. So a bit of a unique practice pattern, but this is right in my wheelhouse. No disclosures. Quickly, I think when we start talking about a topic, one of the things that I enjoy is kind of laying the foundation and really lowering your expectations. And so one of the first things that I think is important to say is that we really don't know much about this disease process. And I feel like I say that over and over again to my residents about pretty much every topic that we bring up. It's much easier to talk about what we don't know than what we do. And then we follow that up with all these things that we thought we knew that turn out to be completely wrong, right? And so one of those is, what is the cause of diverticulitis? And I'll be honest, that consensus conference in London really helped frame this for me. We've all assumed, and if you look at the way that we treat this disease, that this is an infectious etiology. And the truth is there's certainly an infectious component, but things like the AVOD trial and the Diabolo, which I like to call diabolic, were indicated that maybe the infection is less of an issue. So this was a randomized controlled trial, multi-center trial that basically said in uncomplicated diverticulitis and even Hinchy 1 and some 2s that the no antibiotics was the same as those patients treated with antibiotics. So I remember sitting around that table in London, and most of the people in that room, it was about 50% European and 50% American. The Europeans were not using antibiotics in the treatment of diverticulitis. All of the Americans were using antibiotics. So they present us this MCT, RCT level 1 data, and at the end of it they say, hey, how many now are you going to change your practice? And not a single one of us raised our hand. So it just shows you how strongly we hold on to our biases. I was very appreciative of them to kind of bring this to my attention. Again, no antibiotics or compared to antibiotics, no difference in length of stay, recurrence rates, any of those things. So I've brought this back now and have adopted this, and that was one of the things that I enjoyed most. What about percutaneous drainage? Again, this is not damage control. This is just laying the foundation. There's a surgeon in Italy, and we talked about, well, what's the right size for percutaneous drainage for diverticular abscess? Is it 2 centimeters? Probably not. Is it 5 centimeters? Yeah, okay. We can all kind of agree on 5 centimeters. And this guy from Italy literally said, I haven't drained a diverticular abscess percutaneously in the last 15 years. And he said the largest ones that he was using was 15 and 20 centimeter abscesses that he was treating with antibiotics alone. So there's a huge diversity of practice across, certainly in our country and abroad. And so what are the right answers to these questions? This overly simplified Hinchy staging system helps lay the foundation because the treatment for a stage 1 is obviously not the same as stage 3 or stage 4 feculent peritonitis. The pictures are always better in the books. This is more what it looks like in our operating room. Obviously the 1s and 2s are radiographic diagnoses in that top left and top right, with then purulent peritonitis in the bottom left and then somewhat of a feculent peritonitis in the bottom right. So again, it's always prettier in the diagrams than it is in real practice. So what are we going to talk about today? The operative strategies, lap versus open, when is an appropriate response or appropriate implementation of those techniques, various technical options. The data, again, prepare to be disappointed because there's not much and a lot of it contradicts itself. And then at the end, we'll talk about abdominal wall issues and tricks. So let's just begin with laparoscopy. Again, I'm a trauma acute care surgeon, kind of first, but certainly a minimally invasive surgeon as a close second. I think we can all agree that the pros of laparoscopy are the decreased risk of wound complications, the decreased incidence of abdominal wall complications like the one we saw from our colleague at the Cleveland Clinic just a few minutes ago. So anytime we can avoid those complications, I think we can and should. And this is one of the things that my acute care brethren have been slow on the uptake to really increase the number of cases outside of chole and API where they could use minimally invasive techniques. There's there's certainly a decreased metabolic burden for healing, a shorter length of stay in these patients, and there's a higher stoma reversal rate. Well, what about the cons? Again, we're kind of talking about the sickest of the sick. We're talking about damage control, and so hemodynamic instability would be a contraindication for most, not all, to employ minimally invasive techniques. Again, I think this is something that the literature has not borne out. We all say the safe thing, certainly, and if you're in a hotel room talking to a board examiner, you wouldn't want to employ a laparoscopic technique in a patient who is acutely ill. But we all know that in the art of medicine, there are some times when people attempt that, get away with it, and it's probably better for the patient in the end. Obviously, decreased working space with increased edema, small bowel distension. What about access-related complications? You don't do yourself any service by, as you start the case, causing a complication. And then the question of what about a laparoscopic washout? Is it as good as an open washout? There's some data that points to an increased risk of intra-abdominal abscesses when laparoscopy is used. Again, is that a function of the technique itself, or is that a function of the operator and maybe their lack of experience? How do we standardize washout techniques? So there's lots of things here. I think the conclusion is the laparoscopy is safe and feasible in select patients and experienced hands. And I hate that statement because it doesn't mean anything, right? No one can leave here as a broadly applicable guideline, except that you know yourself and you know your patients. The treatment, it's complicated, and I don't just mean that it's complicated diverticulitis. I mean the actual treatment algorithm is increasingly complicated. It actually reminds me of the coagulation cascade from when I was in medical school. It was an extrinsic and an intrinsic, and it was very easy to memorize, and they asked us about it. And now then you look at the coagulation cascade, and it's a full 3-slide algorithm or pathway that is impossible to memorize. So let's begin with laparoscopic lavage, because that's probably the most controversial. You've got the Scandiv trial, Lola, Diala, Ladies. Again, lots of very creative names. Half the trials say that it works and it's worth your time. Half the trials say that it's a heresy. I'm personally a fan. I think that in the right patient, this will save both an ostomy and an open incision. When people quote the 20% failure rate, you think about the failure rate of laparoscopic lavage. Now we're talking about Hinchy 3s, and again, in a stable patient. The 20% failure rate means you just do what you would have done before. So there's not an increased mortality rate that's been proven. There's not an increased risk of an ostomy. It just means that the lap lavage didn't do what you wanted it to do. So don't let people trick you with this 20% failure rate. It sounds much worse than it actually is. There are some patient populations you probably shouldn't consider it in, the ASAs, the immunocompromised, transplant patients, and again, it's not appropriate in the unstable patient. The beauty of it, of course, is it has the potential to avoid an ostomy and a resection and may allow for a one-stage operation at a later date. This is something worth spending some time, because this is something we don't do enough. And I don't mean we, the colorectal surgeons, you guys do this enough. We, the general surgeon, the acute care surgeon, is not utilizing primary resection and anastomosis probably as much as we should. We're still Hartman's people. Our patients, as you heard earlier, they're sick. They're sometimes hemodynamically unstable. But there's good data that shows that even in that sick patient, that you can do a primary resection and anastomosis and then protect that with an ileostomy. And that's better than a Hartman's procedure. It has a lower morbidity, a lower mortality, a lower complication rate, and we should be doing that. And that's something that this collaboration between the AAST and SAGES hopefully will help. It does have a 13% anastomotic leak rate. Again, that sounds terrible because we're used to 1% or 2% anastomotic leak rates, but it means it works 87% of the time, right? So if you can take a sick patient and avoid that anastomosis, or a Hartman's procedure and an ostomy or colostomy 87% of the time, I think that's probably something worth our time. Again, morbidity and mortality is not higher in this PRA group versus the Hartman's. There is a question of, is there a selection bias, right? Are we doing, none of these papers are randomized control trials or very small randomized control trials, and so there's some question of, are we selecting these patients? Damage control, again, it's this 2-stage procedure. You limited resection with discontinuity at the first operation. You saw the VAC, or temporary abdominal closure, that was utilized in these abdominal wall reconstructions. Take them to the ICU, resuscitate them, restore normal physiology, and then take them back at a second look at 24 to 48 hours. The key here is the timing, okay? The longer that abdomen is open, if you've done an anastomosis, there's evidence that shows that anastomosis is more likely to leak. So how can I get this abdominal wall closed in an expeditious fashion The way you do that is by having a schedule and sticking to it. Use the vac. Go back every day or two, wash out, use progressive tension on the tissues. And at the end of the day, this two-stage procedure has shown that it decreases the stoma rate. Hartman's is the gold standard. Again, if I'm in a hotel room with some of our friends from the American Board of Surgery, I still teach my residents to use this and to kind of talk about this first. And then if they ask you to get creative, you have some other opportunities. But it has a higher morbidity, a higher mortality. And then this legacy operation of fecal diversion, the three-stage approach where you divert, then resect, and then restore continuity, still has a limited role, but largely is the legacy operation. Again, this is a simplified version of the algorithm. This is more likely what an algorithm for dealing with complicated diverticulitis looks like. And again, the most important thing here is this isn't going to be pretty. These are abdominal walls that you're going to struggle with. They're going to have some ischemia. The wounds aren't going to look good, but at the end of the day, you're looking for function. Lastly, a resuscitate would be judicious. Time matters. The longer the abdomen's open, as we said, there's an increased risk of anastomosis. Be nice to the fascia. Utilize your adjuncts. There's so many ways to close the fascia now. Dr. Cothran popularized progressive suture closure. There's a Whitman patch. There's these other commercially available. And never do a component surgery separation at that index operation. It's a silver bullet that you don't want to shoot. So in summary, lap techniques are safe in the right hands in the right patient. Most patients can tolerate anastomosis, and we should do it more often. A one-stage procedure is preferred, and the abdominal wall is important to get closed. Thank you so much.